Good afternoon. So one of my favorite things about this event is seeing our community come together and all the chitter chatter in the room that I then feel terrible breaking up because everybody's getting a chance to connect. But I think we have an important event to get to, so I will get us started. My name is Jelaine Arias. I'm the chair of the Grand Rounds Committee, and it's my pleasure to welcome you all to our Grand Rounds for today and for this month. Georgia State hosts the School of Public Health Grand Rounds approximately monthly, where we're able to bring in fantastic speakers, including the speaker today, to share emerging topics and interesting topics in public health. And we look forward to seeing you guys back for future Grand Rounds, including our November speaker, who will be Dr. Elizabeth Miller, who will be joining us from Pittsburgh. But today, it is my honor to actually ask Dr. Harry Heinemann can come up and introduce our speaker. I am told that this is going to be a wonderful introduction, given the personal background and knowledge and friendship that clearly exists between these two. Harry?
All right, so let me just bring the bar down a little bit. Okay. Good afternoon. So it's my real honor to introduce my colleague and friend, Dr. Daniel Driffin. Daniel's career to date really epitomizes what success and impact look like when you ground your work in community. He's worked at the intersection of advocacy and assisting communities impacted by HIV for over 15 years, as a health educator, as a researcher, as creator of a consulting firm, co-founder of a community-based organization, and most recently as the external relations project manager with the HIV Trials Network, which is the most extensive, publicly focused, publicly funded international collaboration focused on evaluating vaccines to prevent HIV and AIDS. Daniel and I first met almost 10 years ago. I don't think my beard was quite so gray then. When he and I were both at Morehouse School of Medicine. He was completing his MPH degree while already having launched Thrive SS, a community-based organization focused on building community and achieving health equity for Black, same-gender loving men. We were excited to have Daniel join our DrPH program in fall 2020, and he graduated in 2023. Before starting the DrPH program, Daniel had already received the Alan Thornell Political Advancement Award from Georgia Equality and the Dan Bradley Humanitarian Award from the Human Rights Campaign, among others. But it's not his many honors and accolades that endears Daniel to his colleagues and friends. It's his humility, his sense of purpose, and his unrelenting commitment to advancing health equity, improving the lives of sexual minority men, and shifting power to help ensure that public health policies and practices are meaningfully informed and led by the communities most affected. I could go on, but I won't. Please join me in welcoming Dr. Daniel Driffin.
Thank you, friend. It's always a little scary when Dr. Hyman introduces you, because I'm a crybaby by nature, so I'm like, oh my God, here it comes, here it comes. But no, thank you. The biggest thanks to the Georgia State School of Public Health for inviting me to just bring some thoughts around something that I hold so dear to my heart, and also to a community that has given me everything. So I'm happy to share just some thoughts of mine around driving discovery and prevention in public health, a focus on HIV prevention. So I really like to start many of my discussions with a data visualization of the impact of HIV across our country. This map is showing the rates of persons living with HIV per 100,000 people as of 2023. The most recent year of data that we have available. The easiest way to make sense of this map is the deeper the red, the greater number of people living in that specific jurisdiction. On this map, it is county level. So the deeper the red, the greater number of people living with HIV in that specific county. Again, this is just a quick snapshot of a partnership of AIDSView between Emory University, the Centers for Disease Control and Prevention, and Gilead Sciences. I like to say AIDSView a couple of times, especially in the day that we live. I don't know how many of you all are on TikTok or any social media platform, but a couple of weeks ago, these crazy videos started going around saying that Atlanta has 19,000 new cases of HIV. And I think it's important that each of us, all of us, especially those within the know, if we have any iota to dispel misinformation and disinformation, please consider taking the time and doing it. AIDSView is a comprehensive home for easy to understand, factually based, and shareable insights on HIV for our nation and key groups unequally impacted by HIV. So I'd like to also ground us with a quick understanding of the human immunodeficiency virus. HIV is the human immunodeficiency virus. Left untreated, it ultimately can become the acquired immune deficiency syndrome. And that's just basically saying it gets to a state where your body cannot protect itself. The virus specifically targets key immune system cells known as CD4 T cells, and the virus uses those cells to make more HIV. The higher the amount of HIV that is in your system, your body, ultimately it weakens your immune system to protect yourself from just everyday common colds, illnesses, and other opportunistic infections. So again, it's real, it's important, and it still matters. HIV is not a disease of the past. You know, we live in a city that's ultimately in a state where we see roughly 2,400 new HIV diagnoses any given year. Across the country, we hover around 32 to 33,000 depending on the year. But even when we think outside of the walls of the nation, more than 1.3 million people learn that they are newly living with HIV every day of the week. And ultimately, you know, those people who are learning that they are now living with HIV sit at the most marginalized intersections of life. You know, we oftentimes lift up those including racial minorities. We lift up those who may identify as sexually minorities. But ultimately, an unequal burden is placed at the intersection of community disproportionately impacted by HIV. We are finally, getting to a place of newer technologies aimed at treating and preventing HIV. You know, I know friends who have lived with HIV for 40 years now, and they actively have a conversation around taking multiple pills multiple times a day. You know, going to sleep and waking up to an alarm clock to take their regimen. You know, oftentimes today, many individuals who are impacted by HIV may be on a single regimen tablet. So going from multiple pills to taking one pill a day. You know, we are also finally at the place where individuals are not even taking a pill a day. You know, to go from multiple pills, one pill, to a shot, you know, every 4 weeks or a shot every 8 weeks. We have seen night and day when we think about prevention and treatment. But again, we still need more innovation to take us to that final step to ensure that we reduce new diagnoses and ultimately increase health outcomes and quality of life for people impacted by HIV, not only here at home, but also abroad. So So the evolution of prevention strategies. This is just a snapshot of, some of the earliest call to actions when we think about HIV prevention. The first one is a snapshot of the Morbidity and Mortality Weekly Report from June 1981. And it really centered a conversation around this new disease, this new illness is being seen across relatively healthy young queer men to not having an immune system. This weekly report chronicles what ultimately will be known as AIDS and HIV, starting with 5 young queer men being diagnosed with pneumocystis carinii pneumonia. The next picture really is a snapshot of the AIDS Coalition to Unleash Power, or ACT UP. I think within this representation, this is a representation of direct to action group, truly galvanizing and demanding change to occur, starting with ensuring that research was available, but also community was not left behind. I think I like to, mention ACT UP around the fact that the earliest organizing group here in Atlanta ultimately, started shortly in fall 1982 with friends that created what is now known as Aid Atlanta. I also lift up these pictures because oftentimes Black people, Latino people, other racial minority people don't have these pictures to fall back on, So we really fall in a paradigm of we weren't there, but we've always been there. We are blocks from the Southern Christian Leadership Congress, and they were some of the earliest groups of folks organizing around saving individuals living with HIV, protecting community with education, and ultimately awareness to turn the tides. And again, we cannot create solutions in a vacuum without all individuals being at the table from start to finish. I think, I highlight awareness campaigns in the context of historical approaches. And oftentimes, these awareness campaigns were aimed at increasing knowledge and educating the public about HIV, specifically, around ways to reduce the spread of the virus. Here are just 2 quick examples, one from the Kaiser Family Foundation and the other from the Surgeon General. I think we have 1 or 2 people in the room who may be young enough to remember when the Surgeon General actually sent this mailer home to every address in the United States of America. Think about it, opening your mailbox and getting this 8-page pamphlet on understanding AIDS. The start of a sector of transformation. Again, I think about what is it to go back to some of the lessons learned from the past, and how can we remix it, to bring new folks to the table. I'm most recently making it back home from Washington, D.C., connected to the United States Conference on HIV and AIDS, and someone shared the fact that there's only 10 legislators in the U.S. House of Representatives that was present when the initial Ryan-White CARE Act was signed. And the Ryan-White CARE Act is the premier piece of legislation dedicated to provide comprehensive core support services and medical support services for more than 1 million people living with HIV in the nation. And the Ryan-White CARE programs take care of roughly 54% of those impacted by HIV here at home. So if only 10 of our elected officials are present from the original date, I think we have some work to do to, bring the other 425 to the same standpoint. The other depiction, again, is some of the earliest examples of using real folks to deliver real messages. So it says, don't worry about HIV, do something about it. You know, for me, I think it's probably 4 images that come to mind when I think of these public campaigns that, you know, really was rooted within fear, tactics, and maybe education. I think of one with like a periscope saying end HIV. I think that came out early 2000s, and it was in red, you know. And I'm like, that's not driving the right messages home. I think of the other one being, I think it was a scorpion or something, and I see some head nods, you know. The message was trying to say, you know, think about how do you protect yourself from HIV, but it did everything other than support, you know, maybe how best to protect yourself. I think even most recently, maybe back in 2016, a report was published by friends at the Centers for Disease Control and Prevention saying that 1 in 2 Black gay men face the lifetime expectancy of an HIV diagnosis. Oftentimes, that's where media stopped the sentence. The sentence continued on if things are unchanged. You know, and I think about those words that were not said, and just the community anguish, and just the sheer disconnect that sometimes, you know, well-intended epidemiologists, evaluators, you know, promotion folks create from, but not how it translates into the community level. You know, so as we continue to create awareness campaigns, as we continue to create solutions for those individuals most marginalized, I ask all of us as practitioners, as experts, to do the extra work to think about how are we communicating and what are we not saying when we, you know, abridge what we do. So continuing on, you know, historically speaking, also we had a real emphasis of behavioral interventions and screening. The earliest interventions, you know, were adapted at aiming, adapted to reduce HIV acquisition across those most affected. Oftentimes, these interventions lived at the intersection of stigma, misinformation, and fear, rather than, you know, evidence-based practices around behavioral change and creation with those most vulnerable in mind. I think about, you know, having the opportunity to interview 10 Black sexually minority men during my dissertation process. And specifically, these men learned that they were living with HIV while delivering HIV services to their community. You know, and they just brought up the importance of how much trust was lost between community-based organizations as a result of creating items in vacuums. You know, oftentimes those individuals who created the interventions and who went through the process of boxing the interventions for implementation and rollout they were opposite from the community that they were serving within. You know, oftentimes at the very last minute, bringing in a handful of folks to say, hey, this is what we did, tell us it's great, you know, versus truly creating from the standpoint of that's not how we communicate about this, you know, like that's not where we go to get services. That's not who we trust, you know. So really flipping the paradigm and having the conversation from the standpoint of using those individuals most impacted from start to finish. You know, having individuals at the table from inception, not an afterthought. And finally, blood screening, you know, truly came online around March 1985. But I would offer you, think about the ethical considerations of, yes, you have a screening technology, yet we don't have treatment yet. You know, what are the conversations that you would walk out with if someone has shared with you that your life is completely different as a result of this novel virus, but not having an answer or at treatment. You know? So again, as we created new opportunities, we were still creating additional barriers that just was not yet bridged for those individuals most impacted. So I like to think of the mid-90s as those transitional years, you know, and throughout these years, we really started seeing the introduction of highly active antiretroviral therapies, or HAART. Long story short, it's targeting the life cycle of HIV at multiple points to stop replication, you know, paired with reliable and point-of-care testing. You know, so imagine going from taking an HIV test and having to wait 7 to 10 business days, if that, you know, compared to, let's think if you got tested around a holiday or the summertime, you know, someone took vacation. So we went from those longer periods of testing to a 20-minute window. You know, again, revolutionary, you know, at that moment, but think about what is the community ramification. You know, I started my career in Florence, South Carolina, as an HIV tester, and the first person that I gave a rapid or a quick test came back reactive. How do you sit with that? You know, how do you have the conversation with someone, again, at the prime of their life, you know, you're now living with HIV, having the discussion of it's not a death condition, you know, you're not going to die from it, but not hearing messages of the opposite side, not seeing individuals thrive or even survive publicly, for that matter, with HIV at the time. You know, so all of these things truly swept into what I call the transitional years. And, you know, most importantly is this last bullet, is the prioritization of federal resources, specifically for community efforts. In 2006, through the help of the Congressional Black Caucus, the Minority AIDS Initiative was codified into law. And these were specific federal resources across the Ryan White HIV care program aimed at improving the health outcomes of Black and brown people. Again, you know, we are now 10 years, you know, from a stark difference of not only individuals dying from AIDS, but individuals living, you know, with HIV. We are also roughly at 2006, 10 years removed from the racial disparities truly being called out like never before. You know, in 1996, 1997, African Americans, the lines switched, you know, in the data, and disparities So finally, dedicated resources aimed at improving health outcomes were available for those individuals who most needed these resources. And this really ushered us into where I call the modern techniques. And first, we have to start with treatment as prevention. You know, treatment as prevention, again, is using ART, antiretroviral therapy, for people living with HIV to prevent new diagnoses. Ultimately, you take your medication as prescribed, and ultimately that medication gets the amount of HIV, your viral load, as low as possible in your body. We see that treatment as prevention stops the transmission of HIV. Across community, we like to call the U equals U, or undetectable equals untransmittable conversation. And this is truly changing a conversation at the intersection of stigma, discrimination, fear, and misinformation. I would also add, this is changing the conversation at quality of life for people living with HIV. I think oftentimes for people impacted by HIV, quality of life is not always front of mind. So I was really happy, you know, sitting at the International AIDS Conference that year, where treatment as prevention, U equals U, was, you know, truly taught from the stage. This also ushered us into a greater conversation on pre-exposure prophylaxis or post-exposure prophylaxis, PrEP and PEP. You know, on the flyer, you may not be able to see it, but it, you know, say PrEP is for people who are at risk for HIV. I would say PrEP and PEP is for people interested in maintaining their HIV status. Okay? Why I say that? Because we have to have a different conversation on risk. Risk-based messaging is not moving folks to new solutions. You know, so if we can have a conversation from a pleasure-based, or just truly acknowledging the fact that life lives, okay? I think we can save more folks than leave behind. Ultimately, PrEP and PEP both are extremely effective when taken. Again, we are at a place where PrEP has gone from a daily pill to an injectable therapy. You know, we have options for PrEP one time a month, one time every other month, and now one time every 6 months. You know, so again, based on your experiences, based on the choices, you have a prevention option available. You know, if you're not a person who likes shots, you have oral options. If you, like me, cannot remember to take a medication, you have an injectable option. You know, it's truly about lifting up a conversation with your medical providers and figuring out what is best for you. Even as we think about more on the development front, you know, what would it be like to take a shot one time a year and protect you from HIV? What would it be like to, rather than take a pill to protect yourself from HIV and a pill to prevent pregnancy, one pill that do the same thing, you know, that protects from pregnancy and HIV? What is it like, you know, taking a pill one time a month for HIV protection? And ultimately, how can we teach your body itself, using broadly neutralizing antibodies or BNABs, to protect itself from HIV? All of these things, you know, are conversations that we can finally have. You know, again, you know, I'm a firm believer of one shot fits all does not fit all, you know. But being able to look at the toolbox of prevention, look at the toolbox of treatment, and offering individuals a choice that they can choose that works the best for them to keep them the healthiest, I think that's powerful. But we can only do that as we continue to challenge these lasting, big-rooted issues, you know. The first one I call intersectional stigma and discrimination. Again, those negative attitudes and beliefs or prejudice towards HIV status. So because you are from this community or because you look like that, you're at greatest risk for HIV. You know, the intersectional part is thinking about the lived expertise of who's in front of you. You know, so thinking about race, thinking about education, thinking about where they call home, whether or not if they have a place to call home. You know, how those lived experiences layer on making an exponential impact of placing you at vulnerabilities for acquisition. Um, you know, we had to have a conversation about accessibility to healthcare services. Not only the fact that we still live in a state without Medicaid expansion, but even, you know, in the best situations of having a healthcare provider or having health coverage, healthcare providers are still less likely to write prevention options for those at greatest vulnerabilities. You know, we continue to hear medical providers sending clients to infectious disease physicians versus, you know, just doing it at your family practice. We still hear conversations on risk compensation. And what I mean by risk compensations, you know, if it's the medical providers thinking that because I'm writing you a prescription for PrEP, you know, you're going to be out here woogieing down, like the camera's on, you know. But we see anything other than that, you know. If you have a patient, if you have a community member who's interested in PrEP, we have to do our business to ensure that they get the solution that they need. Hard stop. You know, and finally, again, thinking of those social economic factors, any barrier that we see across living life ultimately creates a barrier that keeps someone at greatest risk for HIV. So how do we do this in real time? So picture it, my Sicily 2025. Well, it was May this past year. A friend called and said 17 folks were laid off from the Board of Health. And I said, huh? And they shared again, 17 folks were laid off from our sexual health program here blocks away. At any given time, you know, I have a working relationship with our friends at the Georgia Department of Public Health. And, you know, sends a quick little email to our Commissioner of Health, and she writes back. And they are completely in the blind of 17 people being let go. That ultimately created a conversation at the community level of we have to create a community-led HIV prevention portfolio that is sustainable for those most vulnerable, regardless of what happens in Washington, regardless of what happens at 2 Piedmont Street. We have to have a plan of action that can hit the ground and save individuals who need saving the most. Somehow, from May through July, we hosted a series of community sessions. 160 people showed up, and using a charrette-like model, we created what is now known as the Georgia Community Prevention Project. The project is truly aimed at creating solutions for those most vulnerable and most likely to fall through the cracks, regardless of what funding should do, you know. We have 4 buckets of activity. The first one is dedicated to treatment as prevention. Ultimately, you know, improving same-day art, re-engagement, and undetectable equals untransmittable messages to stop new cases. You know, any given time, we have roughly 2,000 folks within our metro center that have yet to reach viral suppression. You know, as long as those people are not virally suppressed, they can create new HIV cases, you know. So we are focusing on that 2,000 to touch immediately to get them back into care, to get them undetectable, and to help them around holistic solutions. Our second conversation is truly around the people's, what we're calling the people's purse. And this is a community-governed microgrant project that funds high-impact, equity-centered activity. Third up is our HIV testing ecosystem to really stand up not only routine testing where it currently does not exist, but also stand up a testing portfolio for individuals to tap into while at home, you know. So using home-based testing technologies to, you know, not only start the conversation around knowing your status, but also starting a conversation to ultimately get into our fourth bucket, which is a PrEP or PEP scale up. And again, you know, this is just increasing marketing, health engagement to normalize and support persistence to maintain individuals to be the healthiest that they can do. Right now, as we stand, this time through December, it's our initiative launch. We aim to launch not only a community request for proposals on World AIDS Day, December 1st, but we also aim to secure additional non-traditional resources to put into this model to help individuals who need help the most. And this is only through what this slide drives home, you know, and is community involvement in education. The top of the slide says, you know, people don't care how much you know until they know you care. And I think if nothing else sticks out, that's the driving home message for me, you know. And this is, you know, just made to be true through grassroots movements and peer education. Of course, letting community, listening, you know, listening twice as much as you speak, but having community identify the problems and creating solutions together that not only improves ownership, but also ultimately improves the likelihood of, you know, should you have to step aside, community keeps it, you know. And finally, peer education. I think we change much more frequently from our friends versus folks who we see as experts, you know. So being able to have individuals that you can identify that speaks your common language is magical and is totally the way forward. Looking ahead, and you know, prior to coming over here, I had the opportunity to talk with some students, and I feel so seasoned saying that I had the opportunity to talk to some students. And one of the lasting questions was, what can we do now while all of the funding changes? And I said, fight. We can still fight. You know, earlier this week, last week, we had, it was like a telethon. It was like old school PBS, you know, like from all day long, scientists from around the world joined 24 hours to save AIDS research. And it truly just galvanized and lifted all of the amazing work that is going on that HIV has provided us over these 4 decades. You know, I didn't say it in this slide deck, but our COVID response is completely built off of our HIV infrastructure. You know, literally having the opportunity to work at the HIV Vaccine Trials Network, we received a call from the National Institute of Health saying, hey, can you all stand up a COVID prevention network? All of the people who have ever created an HIV solution stopped doing work on HIV, and we started working on COVID the next morning. You know, and within 9 months, we have sequenced the virus and ultimately have created a handful of options for vaccines to test the efficacy. You know, within 11 months, shots were going in arms. You know, so we cannot discount what HIV has done for all of the medical So that really also gives me hope as we look ahead. Um, Community must drive the discussion, though. Again, we have to keep those most vulnerable on Main Street in the conversation. We have to rally community to also have these one-on-one conversations with our elected officials at every level, not just our federal representation, but the folks right here on Piedmont, right here on Pryor Street, right here on Trinity. We have to go in and say, this is what we need and this is what we expect. And be willing to go back, before the next election cycle and say, hey, this is what we wanted, you didn't deliver, so, we're going elsewhere. So I offer that. I think also, looking ahead at vaccines and additional long-acting agents. Again, when I think of the opportunity to give an individual a choice to go from daily pill taking to long-acting is revolutionary. I think of the conversations that individuals have shared with me, of the debilitating factor of twisting a bottle of medication and having to swallow it and remind that they are infected, to getting a shot every 8 weeks. Just completely new paradigm that we have not been in prior to now. And finally, thinking about gene editing and using additional technology like CRISPR to really target and eradicate HIV, creating a new or creating an ongoing discussion at what does it mean to potentially be cured, and what are the ramifications of cure amongst a population that has been beat up for 4 or 5 decades. So fight, continue to fight, and we will continue to get through this together. So call to action. Again, the AIDS crisis is not over. I think each of us have some role in ushering in additional solutions, ushering in a new paradigm of not only hope and wellness, but most importantly, wholeness for individuals vulnerable to the virus. Again, innovation is sparked through community involvement. I've been blessed to create community solutions on the back of napkins time and time again, and that is listening to community. And finally, strategies just must be adapted to create solutions for all. So I hope I leave you with something. I am, again, extremely thankful for my home, the School of Public Health, for inviting me to bring some words. And I say fight, fight, fight like never before. So just citations, and I think we can open up for questions and comments.
So if folks will raise their hands, there are microphones being passed around, and we're going to start right, not too far from me. I think I can make the stretch, yeah.
Hello, my name is Jaden Hightower, and I'm a senior public health major. I have a concentration in health policy and behavioral science. My question is, what can we do to prevent the growing stigma that only queer men can get HIV? And how does it negatively impact to thinking of like the growing? Sorry, just the first part.
So thinking about changing the paradigm around only queer men can acquire HIV. I think again it starts with community. I think we have to not wait for industry to create community-centered messaging. I think, at the earliest onset of the epidemic, it was just folks taking pictures, and I think we can go back to that. I think of one of the activities that I had the opportunity to witness during my days at Thrive Support Services was what we called the I Thrive campaign. And Thrive stands for Transforming HIV Resentment into Victory Everlasting. But ultimately, it was a photo voice project. We gave a camera to a person living with HIV, and we had them scout an area of the city to take pictures and come back, develop the pictures, and create an I Thrive statement. Basically, it said I thrive with HIV because ... We had roughly 6 or 7 iterations. It's probably about 100 pictures connected to those campaigns. But we've seen millions of impressions, on social media as a result of individuals standing in their truth and sharing, why they are thriving with HIV. I think we can do the same thing. We do not have to have millions of dollars to create a campaign. I think I'm a firm believer of creating a solution in spite of having the resources will catch up. So that's what I would offer. I don't know if the people.
Great talk, Daniel.
Hey, Fred.
Hey. So I was really interested when you were talking about how you adapted your strategies. I'm not familiar with the charrette-like model. I was hoping you could explain what that was and how you had adapted it to reach the community.
Which strategy? Well, so I think for me, I think of the nuts and bolts of, behavioral change, either using, theories of change or the health belief model. I start at, the simplest molecule. I was sharing earlier, as the nerd that I am, I put together Lego sets to de-stress and, center me. Every Lego box is the same. Every Lego set has the same 6 components, and it's truly just figuring out how best to put it together to get to a different solution. Oftentimes, that getting to a different solution is just listening to folks. I think about even my work with the Ryan White Planning Council, the council that takes care of 18,000 people with HIV here in the city. We always heard folks saying, I can't get to my appointments in time because of work. So roughly 3 years ago, as a pilot project, we wrote into the RFP process, the request for proposal process, that organizations have to pick one day out of their week to stay open late. You had to either open before 7 a.m. or you had to stay open 6 p.m. And if you really want to score points, figure out a Saturday, to be open and provide services. Within a 3-year cycle, we saw re-engagement and retention increase. Ultimately, we see the highest level of virus suppression in our jurisdiction than we've ever seen before. So again, for me, it's just listening to what people are saying, thinking about how can we make sustainable solutions, and figuring out how do we bring resources, to help organizations meet folks, where they are key impacted.
Oops. I'm going to try not to fall down while I ask this question. Thank you so much for a great presentation. So you touched on a couple points I think are so important in terms of like the need for advocacy and need to like tell the story of the importance of this work to policymakers in particular. And then your comment about how kind of the investment that has been made into like HIV/AIDS prevention infrastructure has been has created a situation where other public health outcomes benefit, like COVID. There's a risk right now that I think most policymakers don't understand, that the majority of funding for state health departments is from HIV/AIDS prevention, right? Like Ryan White, CDC funding, so many programs that is the engine for state level health department prevention for all of their work, not just HIV. And so I guess I'd love to get your thoughts on how we can better tell that story, that if that, because that funding is at risk right now, and if that happens, then that's money that has to come out of state coffers because the federal funding is not funding it, right? And I think a lot of governors and state legislatures are right now burying their heads in the sand about that. But somebody has to fuel that work. So I don't know if you have any thoughts on how we can engage like community activists, nonprofits, the public health community to really tell that story of how important this work is, not just for this one outcome, but for the entire infrastructure.
Absolutely. So much smarter people than me, and a great friend, Greg Millett, who is the VP of Policy at AMFAR in DC. He actually did the Dr. Melanie Thompson lecture at Emory earlier. I don't know what week it is. Time is a social concept. But he was here, the other day. And I would share to you using some of the things that his shop is doing. So ultimately, they have a paper free on their website that shows if 50% of HIV prevention resources were to be removed. We literally could see upwards of 75,000 new diagnoses in our country. Okay? If 100% is removed, we are teetering into 100,000 new cases, So I think is using those types of things to elected officials. One of the things that, we are aiming to do within the Georgia Prevention Community Project, using AIDS View and actually having a conversation with each of our legislative officials here at the Gold Dome. The folks at AIDS View are amazing, and they truly work for community. So we started a conversation asking, can you create congressional AIDS View maps for everyone in the House? We are in this time, especially since folks go back into the session in January. It's sitting down one-on-one and saying, this is the impact of HIV in your community, in your elected community. If these dollars disappear, this is what could happen. Again, sharing with students today, our governor has a piggy bank in a brown bag with $16 billion of surplus money in it. We should be demanding, what should these dollars go for? Brian should be leaving relatively soon. So we have a new governor coming to receive $16 billion in a paper bag. So I think it's now the opportunity to have a conversation with anyone interested in being our governor to ensure that the priorities of community are outlined. And I even think of our elected officials. The first thing that they do here at the Gold Dome is our state table budget, So again, opportunities to appropriate resources for things that we value, So I think it's organizing, pulling people together, and I would, also say, pairing multiple communities together to create a multi-impacted situation to move the conversation to a different standpoint. Absolutely.
Hi. My question is, how can college campuses, like the health department, not the health department, but the health awareness organizations on campus and the School of Public Health, work with students to kind of like implement these resources? Because oftentimes we're taught these resources and we leave the classroom, but we're not actually taught with like how to apply these resources, like with like real world experiences.
So I say, A, students have the power. I would gift to you, pull other students together and say, this is what you want. I would also gift to you to write down this name, David Malbranch, okay? Malebranche, okay? He's also 2 rows behind you, okay? FYI, okay? He's 2 rows behind you, right here, this gray shirt, okay? Yeah, him right there, who's laughing. Subject matter expert when it comes to sexual health and student health, and I think it's pulling on folks who live in our community, okay? It's pulling his papers, is creating a one-pager for the folks that you'll be talking to, to say, this is what we want to see, and this is why. I mean, at the minimum, if you shoot him an email, he'll take you for wings, and who don't love a lemon pepper wing, but it's creating pipelines like that to affect change in our community. I have to give I think Stephanie had a question, okay. But I also have to give a shout out to the bestest DrPH cohort. So I think I have 2 in the audience right now. So class, 2023, 2020 class, hey, it's so alive. So thank you for being here, friend. Go ahead.
Yes, it's so exciting to see you, and you did such a great job. I just wanted to ask what you think, what were the strategies that the HIV community used to really combat, back in the 80s especially, that administrative misinformation that was being conveyed? And I'm saying that with kind of a specific angle, too, with what the current administration just said on Monday about autism, and just seeing what were some of the strategies that were found to be effective to move out of that.
I think we have to go back to day one of this. I think we had to go back to die-ins. I think we have to go back to throwing ash on people. I think we just have to go back to calling our friends at the media sources and be like, hey girl, we're gonna be here, bring a camera, okay? I just think where we are, business is not usual anymore, and if these are folks who live on a media cycle, meet them where they are. It's just calling, truth to power. It's calling our friends. I mean, I hate pizza, but if you buy a pizza and tell me to be somewhere, I'll come through. But I think it's just going back to where we started. I also think it's telling the stories that just aren't told anymore, and ensuring everyone knows the impact, because I think everyone is impacted. I think of anytime I'm anywhere, especially at an airport, and as soon as I say I'm in HIV prevention, someone completely, I'm not related to or have no similarities with is saying, oh, I had a brother, I had an uncle, I had a nephew impacted by the disease. And what those conversations start from there. So I think it's really, going back to the building blocks of where we have come from to move us to a different destination.
Unfortunately, all good things have to come to an end. Can we please give Daniel another round of applause, please? Again, thank you so much for joining us, and we look forward to your continued leadership and look to you for hope in these challenging times. Thanks, everybody, for coming.